Hi, welcome to Topic 5, Cardiovascular Disorders Part 3. In this screencast, we'll be talking about heart failure and circulatory shock. First, we'll start with heart failure. Heart failure is a generic term that's used to describe different types of cardiac dysfunction that together result in an inadequate perfusion of tissues with blood. It involves an interaction between a decrease in the pumping ability of the heart with a consequent decrease in the cardiac reserve and adaptive mechanisms that are going to help to maintain cardiac output but end up ultimately contributing to the progression of heart failure. With heart failure, we see a decrease in cardiac output and stroke volume, and this is going to result in less blood to organs and tissues. And secondarily, we would see backup congestion behind the affected ventricle. For instance, if the left ventricle were to fail, then blood would back up into the pulmonary venous circulation, to the pulmonary capillaries, and result in pulmonary edema. One way we can define heart failure is whether it is systolic failure or diastolic failure. Systolic failure is also referred to as reduced ejection fraction heart failure. And this is when we have an inability of the ventricle to eject an adequate cardiac output despite a normal blood pressure. It is defined as a decrease in the myocardial contractility or efficiency of the heart to pump with an ejection fraction of less than or equal to 40%, whereas normal is 65%. Now let's remember what ejection fraction is. Ejection fraction is the percentage of the end diastolic volume that is pumped out with each beat. The decrease in ejection fraction and cardiac output is going to result in an increase in the end systolic volume. That will lead to an increase in the end diastolic volume, and ultimately that's going to cause ventricular dilation, okay, as we have more and more blood in the ventricle that can't be pumped out. This increase in end diastolic volume, which we refer to as preload, is compensatory at first because it's going to help maintain stroke volume and cardiac output via the Frank-Starling law. However, this accumulation of blood in the ventricle, and then which backs up to the atria and then backs up into the circulation behind the failed heart. So once again, with left heart failure, this would be a backup of blood into the pulmonary circulation. Now this is caused by conditions that impair the contractile performance of the heart, such as with ischemic heart disease or cardiomyopathies. It is also caused by conditions that produce a volume overload. For instance, a valvular insufficiency, or with anemia where we have to pump out a greater volume of blood. Or conditions that generate a pressure overload of the heart, such as hypertension and valvular stenosis. So all of those things, the bottom two things, volume overload or an increased pressure overload, are going to cause the heart to wear down faster and eventually can cause it to fail. Conditions that impair the contractile performance, such as could be like a myocardial infarction, or like I mentioned, cardiomyopathy. So the heart muscle isn't pumping as effectively as it once was. Okay, let's take a minute and look at this figure here. It shows cardiac output in liters per minute plotted over the left ventricular end diastolic pressure in millimeters of mercury. Curve A shows a normal myocardial function curve with a normal cardiac output and an optimal left ventricular end diastolic pressure. Okay, so shown right here at 12 and 5 liters per minute cardiac output. B shows a compensated heart failure. So as the heart fails, then we're going to see an increase in the end diastolic volume, and that's going to lead to an increase in end diastolic pressure, and that can lead to it can be compensated. In other words, we can still generate a similar cardiac output, but at a much higher pressure. Okay, and that's shown here in B. So we can still pump out this greater cardiac output, but the heart is going to work harder at that increased pressure. C shows a decompensated failure. So despite an elevated left ventricular end diastolic pressure or volume, we can no longer maintain that cardiac output. And then D shows cardiogenic shock. So we have extremely decreased cardiac output and very high increase in left ventricular end diastolic volume. Next, we can look at preserved ejection fraction heart failure or diastolic failure. And this is when we have a diastolic dysfunction in which the heart is not able to dilate adequately, so it is unable to fill with enough blood during diastole. In this case, it is characterized by an ejection fraction of greater than 50%. So we have a problem with the ventricular relaxation and distensibility, and that leads to an increase in the pressure at any volume. Cardiac output ends up being reduced because we can't fill, because we have a decrease in filling. Tachycardia, or rapid heart rate, can make this worse because there's even less time for filling. And the main cause of this is systemic hypertension. This can also be caused by pericardial effusion and constrictive pericarditis, where the heart is constricted by either fluid or fibrous tissue, myocardial hypertrophy, or a delay in diastolic relaxation, which occurs with aging and hypertension. Okay, in addition to comparing a heart failure as systolic or diastolic, we can also look at heart failure as whether it's primarily left heart failure or right heart failure. So left heart failure is when we have heart failure involving a condition affecting the left side of the heart. So this can be caused by a myocardial infarction of the left ventricle, systemic hypertension, or problems with the valves on the left side of the heart, so the aortic or the mitral valve. This is going to result in decreased cardiac output to the systemic circulation and backup pulmonary congestion. Right heart failure is going to be due to a condition involving the right side of the heart. The most common cause of right heart failure is actually left heart failure. So if you think about it, when the left heart fails, blood backs up into the pulmonary circulation. That's going to cause pulmonary hypertension, and then that's going to make the right heart work harder to pump blood against that higher pressure, and that will eventually cause the right heart to fail. The second most common cause of right heart failure is pulmonary disease. So if we have COPD resulting in hypoxia within the lungs, this is going to result in hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction is going to cause pulmonary hypertension, and that pulmonary hypertension leads to right heart failure. With right heart failure, this is going to result in a decreased cardiac output to the tissues, and here the backup congestion is going to result in systemic congestion. So swollen ankles, swollen feet, swollen liver, swollen abdominal organs, and so forth. Okay, so let's look at some of the manifestations of heart failure. We're going to have fluid retention and edema. So we're going to have increased capillary hydrostatic pressure due to the extra blood in the circulation behind the affected ventricle. We're also going to see increases in sodium and water retention and venous congestion, the venous congestion from the impaired cardiac output. One of the things this can do is lead to increased urination at night. And this is due to increased renal blood flow when lying down. Respiratory manifestations, we're going to see dyspnea on exertion. Cardiac output cannot increase enough to match increased oxygen demands with exertion. We could see dyspnea at rest when heart failure is advanced. Fatigue, weakness, and cognitive impairment. So we have diminished output from the left ventricle, and that can lead to not enough blood flow to the brain, resulting in cognitive impairment. And this fatigue tends to progress as activity increases throughout the day. We can also see malnutrition and tissue wasting in end-stage heart failure. We can have decreased food intake due to fatigue and depression. We get congestion of the GI organs with right heart failure that can contribute. We can also see cyanosis. That's the bluish discoloring of skin and mucous membranes due to excess desaturated hemoglobin in the blood. Central cyanosis, can occur due to reduced oxygenation of arterial blood in left heart failure. So remember, with left heart failure, we can get pulmonary edema, and that would reduce the oxygenation of the blood. We can see peripheral cyanosis, and this is due to excess removal of oxygen from the blood, and this is when we have a slow or sluggish blood flow through the circulation. Arrhythmias and sudden cardiac death. And finally, we can also see some compensations to help maintain cardiac output. For instance, increased heart rate due to increased sympathetic stimulation, and a narrowed pulse pressure due to peripheral vasoconstriction. Manifestations associated specifically with left heart failure include pulmonary edema. Now remember, as the left heart can't pump all that blood out, blood backs up into the left atrium and then into the pulmonary circulation. This is going to increase the pulmonary capillary hydrostatic pressure, so we're going to have more filtration, so that's going to cause the pulmonary edema. This can lead to orthopnea, which is a positional shortness of breath, and also paroxysmal nocturnal dyspnea. This is a sudden shortness of breath, so you wake up suddenly feeling like you can't breathe because blood and fluids pool in the heart and the lungs in the supine position. So sleeping maybe partly upright with pillows behind on your back to help prevent that can be helpful. Cough, and then also the crackles in the lungs. Lung sounds can also be heard. S3 heart sound, this is a rare extra heart sound that can often be heard associated with left heart failure. Manifestations of right heart failure. So now when the right heart fails, then blood backs up into the systemic venous circulation. And this can result in dependent pitting edema, such as in the calves and feet. The Kussmaul sign, that's when we have an increase in venous pressure and jugular distension, particularly with inspiration. Hepatosplenomegaly and ascites, okay, all due to that systemic edema. Okay, and then I'd like you to take some time reading about the manifestations in your book and make sure you can explain the causes of these manifestations. You'll also want to look and compare and contrast right ventricular failure with left ventricular failure and the various signs that you'd see, particularly noting some of the things that are going to be different. Where is the backup congestion? Okay, next I want to talk about compensations. Compensations can help to maintain cardiac output for a time, but ultimately they increase the work of the heart and thus can be maladaptive. So if the left ventricle here is failing, this is going to result in a reduction in cardiac output. The reduction in cardiac output is going to trigger baroreceptors, resulting in an increase in sympathetic reflexes and sympathetic stimulation. So this is going to result in an increase in heart rate. It's going to result in an increase in cardiac contractility. It's also going to stimulate the peripheral vasoconstriction, which is going to result in an increase in total peripheral resistance. Okay, so we can see how the heart rate and the increased contractility are going to increase the work of the heart. And then also, if we cause an increase in vascular resistance, this is going to increase the afterload and increase the work of the heart. Okay, secondly, the reduction in cardiac output is going to result in a reduced renal blood flow, and this is going to activate the renin-angiotensin-aldosterone system. This is going to result in the production of angiotensin II, which is also going to cause vasoconstriction and increase the vascular resistance. Angiotensin II will also act on the adrenal gland to cause the release of aldosterone. Aldosterone will stimulate sodium and water retention, an increase in vascular volume. This will increase preload. This will help to increase stroke volume via the Frank-Starling mechanism, but this is also going to increase the work of the heart. A dilated ventricle is going to require more tension on the wall to generate the same pressure. So that increase in preload is going to require more tension to generate that same pressure. And this is going to result in myocardial hypertrophy and remodeling. So we're going to see an increase in wall thickness, and that is going to increase the oxygen demands of the heart. So all these things, while helping to maintain cardiac output, can ultimately cause the heart to fail more quickly. Okay, and then you should take a few minutes to go over these concept check questions. And the test your knowledge question. So describe whether each of the following is likely to cause systolic failure, diastolic failure, or both, and if it will result in left or right-sided heart failure first. Myocardial infarction of the left ventricle. This would result in a systolic failure of the and left-sided heart failure. Constrictive pericarditis. That's where we have fibrous tissue that surrounds the heart and doesn't allow it to fill. So that's going to be a diastolic failure. Systemic hypertension. This is going to result in increased work for the left side of the heart. So it causes left-sided heart failure. And this could result in both the diastolic and a systolic failure. COPD is going to increase the workload of the right side of the heart, can result in systolic failure of the right heart. Hypertrophic cardiomyopathy, this is where we have a thickened ventricle. It's going to be harder to fill. This can result in a diastolic failure. Aortic stenosis is going to increase the work of the heart to overcome that narrowed aorta. This is going to be on the left side. Systolic failure. Tricuspid valve regurgitation. The tricuspid valve is on the right side of the heart. The heart's going to have to keep repumping the same blood over, and this can cause a systolic failure of the right heart. Okay, then I'd also encourage you to go ahead and read through the test your knowledge question and try and decide which of his signs and symptoms result from compensations due to decreased renal blood flow. Okay, so remember activation of the renin-angiotensin-aldosterone system, which are due to the sympathetic nervous system compensation. So this is activation of the baroreceptor reflex. And think about which side of the heart is failing based on where the fluid is. Yes, fluid in his lungs. True or false? The characteristic pink sputum produced by pulmonary edema is tinged with blood. And this is true. In pulmonary edema, the alveolar capillary membrane is damaged and blood from the capillaries moves into the alveoli. The blood from the capillary causes the sputum to appear pink or light red. Okay, moving on, we're going to talk about shock. Let's first review blood pressure. So mean arterial pressure is equal to the cardiac output times the total peripheral resistance. And remember, cardiac output is the product of the stroke volume times the heart rate. So let's think of which of the following are going to affect cardiac output and which of the following are going to affect the total peripheral resistance. So blood volume. So blood volume is going to affect the venous return. That's going to determine the preload on the heart. The preload then causes or affects the stroke volume, and the stroke volume affects the cardiac output. So blood volume is going to directly affect cardiac output and mean arterial pressure that way. Heart rate. Cardiac output is the product of the heart rate times the stroke volume, so heart rate is going to affect cardiac output. Vasoconstriction. When we say vasoconstriction, we mean constriction of the arterioles. Constriction of the arterioles is going to lead to an increase in vascular resistance or an increase in the total peripheral resistance. Angiotensin II. Directly, angiotensin II causes vasoconstriction, and that would increase total peripheral resistance. But angiotensin II also causes the release of aldosterone, and aldosterone is going to cause sodium retention, and water is going to follow sodium, so that would lead to an increase in stroke volume and cardiac output. Epinephrine. Epinephrine is both a vasoconstrictor, which should cause an increase in TPR. It also causes an increase in heart rate, which is one of the components of cardiac output. It also causes an increase in contractility, which will also increase stroke volume by producing a greater efficiency of cardiac contraction. Histamine. Histamine is a vasodilator, so it would result in a decrease in total peripheral resistance, and that would result in a decrease in mean arterial pressure. Histamine is also going to cause dilation in the veins, and that's going to reduce venous return, decrease preload, decrease stroke volume, and that would decrease cardiac output and thus decrease mean arterial pressure. Venoconstriction, constriction of the veins, this is going to aid in venous return, increase preload, increase stroke volume, increase cardiac output, and increase mean arterial pressure. Just kind of understanding how these things can affect cardiac output and total peripheral resistance will help us to understand how various things can cause shock. Okay, and those are all written out here if you'd like to take a minute to review them in the written format. Okay, so shock occurs when the cardiovascular system fails to perfuse the tissues adequately. This is when that mean arterial blood pressure is so low it cannot adequately perfuse all the tissues. This can be divided up into 4 main types. Hypovolemic is when our blood volume is too low. Cardiogenic, which is when we have pump or heart failure. Obstructive, when we have obstruction of the flow of the blood through the central circulation. And distributive, which is when we have a loss of blood vessel tone and enlargement of the vascular compartment. Distributive can be further subdivided into septic shock, neurogenic shock, and anaphylactic shock. So first let's review our normal circulation. Our normal circulation, we have adequate oxygenation from the lungs. We have normal circulating blood volume, and there is no obstruction in the circulation. It is not impeded, and blood volume is normal. Okay, our first one is hypovolemic shock, and this is characterized by a diminished blood volume such that there is inadequate filling of the vascular compartment. So if we have not enough blood volume, and we can see this is illustrated by this dashed line, so we have less blood volume, then we're going to have a decreased venous return back to the heart. If we have a decreased venous return, we're going to have a decreased preload, a decrease in diastolic volume, a decreased stroke volume, a decreased cardiac output, and thus a decreased mean arterial blood pressure. This is caused by an acute loss of circulating blood volume of about 15 to 20%. This can be due to a loss of whole blood, such as with hemorrhage. This can be due to a loss of plasma, such as with severe burns. It can be due to a loss of extracellular fluid, such as could occur with very severe dehydration or loss of GI fluids. And this can also be caused due to third spacing, loss of fluid to a third cavity that it's not circulating. So if the blood volume drops, then the heart rate is going to increase. We're going to get tachycardia to try and compensate. And this is going to result in the clinical signs of a weak and thready but rapid pulse. So we're going to have tachycardia, but the pulse is going to kind of feel weak or thready. Hypovolemic shock is the most common form of shock. This slide looks at some of the compensations that occur as a result of hypovolemic shock. So we have some mechanisms to maintain cardiovascular function. We're going to see an increased heart rate and cardiac contractility. In the blood vessels, we're going to have vasoconstriction of vessels in your skin, so the skin will be like pale, as well as non-vital organs. Other mechanisms to help maintain blood volume, we're going to have stimulation of thirst by the hypothalamus. The posterior pituitary is going to release antidiuretic hormone, which will act in the kidney to increase water reabsorption. We'll have the activation of the renin-angiotensin-aldosterone system, and aldosterone is going to cause sodium retention. So we'll have sodium and water retention, decreased urine output. In the liver, we're going to have constriction of veins and sinusoids with mobilization of the blood in the stored liver. That's been stored in the liver. Cardiogenic shock. This is when we have pump failure, failure of the heart. So the heart cannot sustain an adequate circulation. So this is going to be due to a decreased contractility or contractile force of the heart. This is going to cause a decrease in stroke volume, a decrease in cardiac output, and a decreased mean arterial pressure. The decreased blood pressure is going to lead to hypoperfusion and tissue hypoxia, even though we have an adequate intravascular volume. The heart just can't pump it out with enough pressure. The usual cause is myocardial infarction. This can also be caused by arrhythmias and congestive heart failure. The decreased cardiac output lowers the blood pressure, and we're going to see a response by the sympathetic nervous system that's going to cause vasoconstriction to raise blood flow. But the increased resistance to blood flow is going to increase the workload on the heart, which is going to worsen the heart failure. Obstructive shock. This is a result of a mechanical or physical obstruction of the flow of blood to the central circulation, which involves the great veins, the heart, or the lungs. This can be caused by a massive pulmonary embolus, say blocking the pulmonary trunk, cardiac tamponade. Remember, that's the sudden accumulation of fluid in the pericardial sac, a pneumothorax, or a dissecting aortic aneurysm. Sometimes obstructive shock gets lumped under cardiogenic shock, but usually it's considered by itself as obstructive. Okay, finally, distributive or vasodilatory shock. This is where we have a loss of blood vessel tone that leads to enlargements. We see an enlargement of the vascular compartment. And this is going to cause displacement of the vascular volume away from the heart in great circulation, and, if you will, a pooling of blood in the vasculature. So here our blood volume is normal, but our perfusion pressure is poor due to this loss of vascular tone and abnormal expansion of the vascular bed. And this is caused by extreme widespread vasodilation. So the arterial dilation is going to lead to a decrease in total peripheral resistance, and this is going to directly decrease mean arterial pressure. And so that's arterial dilation. Venous dilation is going to lead to blood pooling in the venous circulation, and that's going to lead to decreased venous return, decreased preload, decreased stroke volume, decreased cardiac output, and that's going to lead to a decrease in mean arterial pressure. So as I mentioned earlier, this includes three types: neurogenic, anaphylactic, and septic. Neurogenic shock occurs when we have a loss of vascular tone due to a loss of sympathetic nervous system stimulation of the vessels. And this is due to a defect in the vasomotor center of the brainstem, or the sympathetic outflow from the brainstem to the blood vessels. This can be caused by brain or spinal cord injury. So this occurs like with spinal shock, for instance. Anesthetics or depressant drugs. Insulin shock, that lack of glucose, can affect the brain and cause loss of sympathetic stimulation. Hypoxia as well, or severe pain and emotion. In contrast to the other types of shock, the heart rate is slower than normal, and the skin is warm and dry, and that's because we have a decreased sympathetic outflow. Okay, so that's also, so we're not going to see that compensatory response of the heart rate or of the blood vessels of the skin. Okay, because we have decreased sympathetic outflow all the way around. Anaphylactic shock we talked about earlier, but this is the systemic response due to inflammatory mediators such as histamine, acetylcholine, leukotrienes. And these are released in a type 1 hypersensitivity reaction. This leads to vasodilation of arterioles and venules and an increase in capillary permeability. So not only do we have an enlargement of the vascular compartment, but that increase in capillary permeability allows fluid to leak out. So in addition to vascular problems, as noted before with anaphylaxis, we can also get laryngeal edema and bronchospasm, and that makes oxygenation even more difficult. This is a common cause for response in sensitized people as a result of medication reactions, nuts and shellfish, stings from bees, wasps, and ants, and latex allergies. Septic shock is the most common type of distributive shock, and this is defined as when we have severe sepsis with hypotension. This can often occur in critically ill patients. So this is a result of a systemic immune response to a severe infection. So we get this systemic inflammatory response and activation of chemical mediators into the bloodstream. So we get a damaged endothelium in the blood vessels and the release of excess nitric oxide, what's going to cause vasodilation. We get an increase in procoagulant factors and a decrease in anticoagulant factors. We get activation of clotting, the formation of microthrombi, and thrombocytopenia. We get arterial and venous dilation, plus an increase in capillary permeability, so more fluid leaks out. That's going to cause a decrease in total peripheral resistance and a decrease in cardiac output that together lead to a decrease in blood pressure. We're also going to see fever and leukocytosis, hypoxemia and metabolic acidosis, and this can rapidly lead to multiple organ failure. Okay, let's talk about some of the manifestations of shock. Early manifestations include anxiety and restlessness, and this is due to sympathetic nervous system stimulation that's stimulated by the hypotension. Of course, we won't see this in neurogenic shock because of the depressed sympathetic outflow. We also see manifestations due to compensations. So these are manifestations to help that help maintain blood pressure. So tachycardia is due to increased sympathetic stimulation. Once again, not seen in neurogenic shock. Cool, pale, moist skin. And this is because vasoconstriction is going to shunt blood from the viscera and skin to vital or areas in response to sympathetic stimulation. Oliguria, that's reduced urine output, and this is going to be as a result of activation of RAS and decreased GFR due to the low kidney perfusion pressure. This is going to help to maintain blood volume. Thirst, which is stimulated by antidiuretic hormone and angiotensin II to increase blood volume. Tachypnea, this is rapid breathing, and this is as a result of metabolic acidosis because we're not getting enough oxygen to the tissues. And this is going to help to blow off CO2, which will reduce the acid load. Progressive signs of shock occur when the compensations are no longer maintaining adequate perfusion pressure. And then we'll start seeing lethargy, weakness, and faintness. And this is due to decreased perfusion pressure and acidosis, depressing the nervous system. And then and metabolic acidosis as a result of anaerobic metabolism, increasing the lactic acid production. This is because we're not adequately perfusing the tissues with oxygen. We have 5 major complications of shock that can often be fatal. Acute respiratory distress syndrome, or ARDS. This is an inflammatory response in which neutrophils enter the alveoli and they release inflammatory mediators and proteolytic enzymes. This leads to endothelial and epithelial injury. We get exudate that then enters the alveoli and that blocks gas exchange. It also dilutes surfactant, and that can lead to atelectasis and severe ventilation to perfusion mismatch. We can get acute kidney injury due to impaired renal perfusion. That leads to ischemia, and that causes sloughing off cells within the kidney tubules, leading to acute tubular necrosis, kidney failure. Gastrointestinal complications, so widespread constriction of blood vessels to the GI tract, can result in decreased perfusion of the mucosa, and that can eventually lead to ulceration and bleeding. We can get disseminated intravascular coagulation, and this is particularly common in patients with gram-negative sepsis, about 30 to 50% of patients. And then multiple organ dysfunction, when we have progressive dysfunction or two or more organ systems. This is the most frequent cause of death in the non-coronary intensive care unit. Okay, and then you should answer the concept check questions. Make sure you can understand distributive shock and why vasodilation of the arterioles and vasodilation of the veins lead to shock. Finally, match these types of shock with their possible causes. And there are the results to that. And that's it.